Dr. Lester Breslow in his office at 1100 Glendon in West Los Angeles. It's on the 20th of June, 1990, and he is being interviewed, in quotes, by Francis Feldman. Dr. Breslow has long experience in the field of health and welfare, especially health, and I will ask him to just start and tell us about that. Let me say a word or two so I can see how your voice is.
I understand that you might want me to start with the story of how I got into public health as a field.
All right, you can just
continue. Well, it begins really at 3 years of age. I won't take you in detail through childhood, but at that time I began to stammer quite severely, a condition that persisted through my school years until in high school my family put me in the hands of a therapist who undertook to help me overcome that disability. She did so, and in the course of it introduced me to what was then known as mental hygiene. And from that I took an interest in becoming a psychiatrist as a high school student. So I finished high school, did all of the pre-medical courses, went through medical school. In my junior year, during the summer, I decided the time had come to really become a psychiatrist. I therefore spent the summer in the Fergus Falls State Mental Hospital, really properly called an insane asylum.
Where was that?
Fergus Falls, Minnesota.
Minnesota.
I was going to school in Minneapolis. And the situation of treatment of people with mental illness was so terrible that I could not contemplate a life of that sort. Of course, people became psychiatrists and did other things, but I was concerned about those people who were really seriously ill in hospitals. So I returned to the campus at the end of the summer, very disheartened.
About what year was this, Les?
This was in the summer of 1937. I was then 22 years old, getting to the end of medical school. And here I devoted the last years of high school, college, medical school, anatomy, biochemistry, all those things in which I really did not have interest, in order to become a physician, to become a psychiatrist. And now it was all laid apart. Fortunately, I met a friend, a young instructor in the medical school, who had taken some interest personally in me. And he said, when he heard my despair, that he never had thought I should be a psychiatrist, that I should go into public health, because now I was getting a medical degree, and that my social and political orientation was such that that would be the proper field for me. So he introduced me to the new, just arrived professor of public health, who was just starting a school of public health in Minneapolis. And that's how I came into the field of public health at the age of 22, before I finished medical school. Well, to go ahead, I finished medical school and also the Master of Public Health program at Minnesota, entered the California department, entered the Minnesota Department of Public Health, and then spent a few years in the Army of the United States during World War II, the last year or so in the Pacific Theater, and came back to enter public health work in California, the California Department of Public Health, as it was known in those days, where I stayed for 22 years, then came to UCLA, where I have now been also for 22 years. So that has been a quick outline of my career. I say I've only been able to get 2 jobs in my whole life.
But those were very prestigious jobs. Did you enter the California program as Director of Public Health?
Oh, no. I entered the California Department of Public Health in January of 1946, having just returned from overseas. The director of the department at that time was Wilton Halverson, a great figure in public health, not only in California, but nationally. Halverson had been picked by Earl Warren, the governor from the early years of 1940, along with a lot of other distinguished professionals in the various health and welfare fields. He had picked carefully outstanding professionals to head the departments dealing with the prisons, welfare, public health, and other fields of that sort. That was a mark of Earl Warren. He not only picked outstanding professionals, but gave them strong support. I didn't know that at the time, but I came to know that in the ensuing years. My first encounter with the department came through an introduction to Dr. Halverson. It had been given by a distinguished person in public health in those days, K.F. Meyer, at the Hooper Foundation at UC San Francisco. Halverson saw me because K.F. Meyer called him on the telephone to see me. Halverson, however, didn't like my ideas of public health. He listened for a few minutes to my great notions of introducing a chronic disease program on the public health scene in California. And after only a very few minutes of listening, advised that I should go back to Minnesota and try out those ideas. It was quite evident that he had no use for them in California. Well, that was a bit disheartening, and after a brief vacation, this was in November, December of 1945, I came back and through a great physician on the staff of the department those days, Jesse Bierman, whom I saw just recently, in great shape, head of maternal and child health of the department, got me in through the back door somehow, and that's how I entered the California State Department of Public Health. I entered as the grade 1 medical officer, the lowest rung for a physician, because they had need for someone to do a project on encephalitis, which I'd had some prior experience, although made very clear I had no interest in that. And took the job only because the immediate superior, a great figure in my career, Robert Dyer, said that he would read my memos, as he called them, about chronic disease. Well, that seemed a fair deal, that at least I would have a chance to convince him to do this. Because that was a new idea in public health in those days. It was still concerned with the traditional things that people perhaps even still think are the guts of public health, namely communicable disease control, maternal and child health, and environmental sanitation, and the like. Well, once having got in and having found a way with Dyer's support and some federal money to get started in the chronic disease field, by the middle of 1946, I entered into a wonderful opportunity in that department. Halverson, as I mentioned earlier, was a great leader in public health, Seventh-day Adventist, but a broad-gauged man who organized and led a wonderful group of people in the department, gave everybody a great opportunity, and was a great mentor for all of us in the department in those days. He was quite conservative in his views about the nature of public health, as evidenced by his reaction to my notions of introducing chronic disease onto the public health agenda. He also, like many leaders of public health in those days, had no time for medical care, even for indigent medical care, as we called it in those days, as a feature of public health. He would personally have nothing to do with it. He would not take part in any of the movements in those days that were beginning, admittedly, on the fringe of public health. I was very much interested in those things. Earl Warren wanted to introduce the state health insurance. He had 5 daughters and had had a considerable amount of medical care experience with his family. And he had the notion in those days that he wanted to leave as an important mark of his career a state health insurance program. Halverson, however, his state health director, would have no part of it. But he allowed me, not with any public notice, to assist the governor's staff in the development of programs, in writing of speeches, and things of that sort. So I used to travel occasionally to Sacramento to meet with the governor's staff and people that were doing the planning and writing to offer what help I could, because I was personally very interested and in touch nationally with what was going on toward getting a national health insurance program underway in those days. One very early experience indicates, I think, some of the tensions in the health field of that period. The very first thing that we decided to do with cancer control monies, which was all we had for chronic disease programming beginning in the late summer of 1946. The thing we decided to start with was a tumor registry. I had visited New York, Connecticut, Massachusetts, some other programs where tumor registries had been started, and I decided that that's the way we should start. An important aspect was, at that time, to get the support of the Cancer Commission of the California Medical Association. It included people who became leaders not only of California medicine, but of American medicine. John Klein, for example, became president not only of the CMA, but also of the AMA, a cancer-interested surgeon. And there were others, pathologists, radiologists, people that were just starting up in the clinical cancer field in those days. So the time came, having talked with the chairman informally and 1 or 2 other members about our plan to start a state tumor registry, to meet with the commission. The time was dinner at a famous restaurant, Jack's Restaurant in San Francisco. On my way to that dinner at 6 o'clock, I noticed the headlines in the newspapers on the stands on the corner. They were a surprise to me, not in substance, but in timing, as they were, I learned, to the members of the Cancer Commission. The headlines were that Governor Warren had introduced his health insurance bill. When I arrived at the meeting of the 9 members of the Cancer Commission, they were so excited about this terrible thing that the Republican governor of California was doing, that they immediately transformed the whole idea of the cancer registry into a scheme by which cancer patients were to somehow be fed into a state medical machinery that Earl Warren was proposing to set up. It was, even in those days, not just in retrospect, the most bizarre notion. But here were these people, very distinguished leaders in California and even American medicine, who had this short circuit.
It's kind of parallel what was happening among similar groups with mental health.
Yes, yeah. Well, the situation was so unnerving for all of us that I literally did not stay for dinner. There was just no way that any of us would be able to eat if I were still present representing this terrible thing that Governor Warren was doing. Of course, they did not have any knowledge that I was otherwise working with Governor Warren, but the tumor registry had nothing to do with the case, of course. Well, as we walked out of the room, the chairman of the commission, a very nice radiologist from San Diego, put his arm around me and said, "Lester, don't worry too much about this. 2 or 3 months I'll call you again. That bill's not going anywhere. They'll forget about it, and things will die down, and this is a good thing to do, and you'll come back and we'll start the tumor registry," which is precisely what happened. But that indicates the feelings of people, and also the attitude of the public health director, who, while he might not have totally agreed with these leaders of medicine, still adopted a policy that would protect the relationship with them, even though it was not supportive of the governor. The governor didn't mind that. He wasn't dependent upon his health director to get his health insurance notions put forward, but that's the way it was. Well, I had a wonderful experience in the department, and as I say, I've learned a great deal over the years. We started the chronic disease program, and put a lot of emphasis in those early days on the tumor registry. We started with 9 hospitals in California, scattered among some of the major hospitals, some teaching, some non-teaching, some public, some voluntary. Those days we didn't have.
Throughout the state? Throughout
the state. I think 3 or so of them were in Los Angeles. And we didn't have the proprietary or profit-making hospitals in those days. But we did have a lot of other hospitals that were treating substantial numbers of cancer patients. And those hospitals have maintained their cancer registries to the present time. And over the years, the idea of tumor registries has taken very strong root in California, elsewhere too, but particularly in California. We developed a county-wide registry for Alameda County in 1960, and subsequently that became a Bay Area-wide registry, and very recently it's become a statewide registry, undergoing some metamorphoses during these years, but essentially the same as it was started back in 1946. And it's provided, of course, a wealth of data. Well, we dealt with a lot of other problems in those days.
Excuse me, did the cancer registry then serve as a prototype for other kinds of registries?
Only in subsequent years. And never to the same extent. We do have registries now, for example, of children born with birth defects. That came along later. And there are registries of other fairly rare conditions, nothing as extensive as I know of as the cancer registry. Various people around the country and the world have tried to develop such registries, but there's always been some debate about their worthwhileness, even of the cancer registry. But it seems to have taken strong root now, not just in California, but elsewhere as well. In those very early years, I could recall any number of experiences, but let me just mention
Go ahead.
a couple. One was the great poliomyelitis epidemic in Los Angeles in 1946. That was the year I mentioned earlier that I entered the department and was assigned to work on an encephalitis study. That June of 1946, I was called off the encephalitis study and assigned, as Halverson said, he'd somehow discovered me in the department, not having admitted me through the front door, however, sent me down, as he put it, to take charge. That was his word. Take charge of the poliomyelitis epidemic. That summer we had over 2,000 cases of recognized poliomyelitis in Los Angeles. Lord knows how many unrecognized cases occurred. And there were various efforts made to deal with the epidemic. But
was this a more extensive epidemic than the one in the mid-30s?
well, I wasn't here in the mid-30s, and I only heard vaguely about that, but it was a very sizable epidemic. And what we mainly did from the State Health Department was to handle the public relations aspects of it, giving support especially to the people in Los Angeles County who were endeavoring to provide medical, hospital, and later on rehabilitation services. A wonderful program was developed here by the people in Los Angeles County, including care for, I remember, over 100 patients at home with what in those days we called the iron lung. That was a very elaborate contraption, very heavy, which had to be supported by standby generators in the backyards of the people. In case electricity should fail, they would be without life support without that standby generator. So that was an important feature of dealing with an epidemic that, of course, we no longer, hopefully, will ever see in this country, and hopefully not too far in the future in the world. But that was a feature of our work. I also recall, during those very early years, being assigned to join the Berkeley City health officer in vaccinating people against smallpox in the face of an epidemic in the late 40s. The epidemic actually never materialized as such, but there were a fair number of cases that occurred in the Bay Area. And to abort that threatened epidemic, health officers lined up people to come for smallpox vaccinations. This man needed physical assistance by young doctors, so I had that experience of standing at the head of a line of hundreds of people lined up around the block in Berkeley to receive smallpox vaccinations. Well, of course, nowadays smallpox has been eliminated from the world, and in my memory, we still had the public health challenge of that disease. Moving ahead a little bit in years, another great health problem that we encountered in California in the early 1950s was air pollution. during the 1954, 53 or 54 gubernatorial campaign, when Goodwin Knight, who had succeeded Earl Warren as the Republican governor, when Warren went to the Supreme Court, Goodwin Knight was running against the Democratic candidate for his first election as governor. In the midst of that campaign, the summer, I'm not sure if it was 53 or 54, a very severe episode of air pollution affected Los Angeles County. It became a factor in the political race. Unfortunately for the Democratic candidate, he lost his voice about 3 weeks before the end of the campaign.
Because of the pollution?
I don't think it was because of that. But in any event, Goodwin Knight was running, I guess as the politicians say, scared. So that on the 1st of October, before the election, early in November, he called upon the State Department of Public Health, headed by Halverson in those days, to find, as he put it, when smog becomes a killer. That was his charge. When does smog become a killer? The fear in those days arose from experiences in England, Lenora, Pennsylvania, and other places where there had been episodes of considerable number of fatalities as well as severe illness.
That was
smog.
Called the yellow fog.
It had a lot of names. Actually, it was more brown than it was yellow. But that's right, it had a lot of appellations. But Knight wanted to, I suppose, get out of some of the political heat by having called on his department a month or so before the election as having taken all the stand that he could by calling his health department into the situation. We were instructed to bring in a report by the 1st of March, when he would hopefully, and he was, elected governor of the state. We did that, and the report, I recall, was called Clean Air for California. It was, I suppose, the state of the art, but it did indicate that public health in those days entered quite substantially into political thinking. And I believe in a way that is more thoughtful, substantial, than the way, let's say, the AIDS epidemic has entered into politics. The governor called on the health department to prepare a scientific report. We did the best that we could. And as a matter of fact, even the phrase that we used in that report, Clean Air for California, has become a kind of a slogan, a notion of clean air as the concept for air pollution control. So we were fairly proud of that report. Unfortunately, it didn't have a great deal of impact because the election was over. Air pollution became quite powerful in especially some parts of Los Angeles almost every fall during the 50s and into the 60s. And we can go back to air pollution perhaps a bit later. Or should I go ahead and complete that story?
Why don't you?
All right. So we did that work on air pollution during the early 50s. When Pat Brown, as some of us say, the real Governor Brown, came into office in 1960, 59 I guess it was, he dispatched a couple of his high lieutenants, very bright attorneys who had been with him during the campaign and helped get the administration underway, came down to see a couple of us in the state health department. John Maga, a public health engineer, and myself on the medical side. I think they came right by Malcolm Merrill, who was by that time a successor to Halverson and the head of the State Department of Public Health. They knew the names of the people that they wanted to talk to. So they came to us and said that they wanted to have another report on air pollution, this time one that would set the standards, the chemical standards, for the ambient air, that is, the air that people breathe out of doors everywhere. What amount of carbon monoxide and sulfur and other materials would be allowed in the air, ozone, nitrogen oxides. Not only would the report do that, but since they were convinced, these two bright attorneys, that air pollution came largely in California from the exhaust pipes of automobiles, that we should further specify what limits should be placed on automobile exhaust.
Just checking that he's still there.
John Maga and I thought this was an off-the-wall idea. It was a marvelous concept, but we felt totally unfeasible. How could we possibly do that? But there was the instructions, and we had to do it again in a quite short timetable, because the governor wanted to have this accomplished early in his administration.
Did he get this idea out of his own experience and head, or were advisors suggesting it?
I don't know where it came from. It certainly didn't come from us in the health department. It might have come from such attorneys, or he might have thought it himself. He, of course, had experience. He'd been the San Francisco district attorney, but he'd been around the state. He knew, as state attorney before he became governor, what was going on in Los Angeles and a few other cities in the Southland. Where the idea come from, I don't know. But it clearly came from his office and was carried. Well, John Maga and I then scratched our heads and went to work, assembled an expert committee, including several Californians and several people from across the country who we found to be the most expert in this question: what standards should we allow for the ambient air, and then how could we translate those standards to the number of automobiles and how much should be allowed to come out of the tailpipe. With the very substantial help of this expert committee, we then proceeded to do precisely what we'd been asked to do. We went to the State Board of Health some months or maybe a year or so later, no longer than a year, when Roger Egerberg was by that time the chairman of the State Board of Health. And the board had the power in those days to adopt such regulations. It didn't, in those days, have to go through the legislature or go to an initiative to the people to vote on. It was done in regular, governmental, well-established channels in which people had confidence, because those channels were working, as they did in this case. The governor asked his agency, which called upon the best experts it could find, locally and in the state and nationally, took those expert opinions and studies, formulated a report. We had recommendations to deliver. And we did. And the board had the power, being appointed by the governor and with broad statutory authority, to adopt those regulations, which it did. And it did so in a public hearing, which I remember very well, in the small auditorium of the department in Berkeley in those days, which was filled with the people from the automotive, oil industries who were intensely interested in this proposition. You can imagine what the situation would be like nowadays, where this would be handled in some obscure way in Sacramento with lobbyists and legislators, and in some of their, I must say, nefarious negotiations, making the decisions. This was all done with the style that I've just outlined to you, and done in a public meeting with the experts as well as the legal talent of the big industries, oil and automotive industries, brought in to see what was going on, to object, and to challenge it, as is quite appropriate, of course, if they felt that there was a basis for a challenge. Well, they listened to the report. They were given an opportunity to make comments, to ask questions. They had none. The board adopted the recommendations, and they were never challenged in California, at least in those early days, the way we formulated them, that first basic set of recommendations. And that became the basis for the air pollution control program, not just in California, but in fact across the country. And everyone is familiar, of course, with generally what has been happening with efforts to get Detroit, as the automotive industry is called, to establish proper controls on air pollution in California and elsewhere in the country. So those were exciting days and opportunities in public health. And I emphasize the style and the manner of the work as being so different from what it is nowadays, what would happen nowadays.
From the perspective of the governor as well as departments and the public.
That's right. And the industry.
Mm-hmm. And the industry.
Now, of course, our relationship has been all turned topsy-turvy, and everybody is dissatisfied. The industry, the public, I suppose the politicians, mm-hmm. the experts, nobody is happy with the situation. And so in that respect, I suppose I am pleading for what people might say at my age I look upon as the good old days. I think, however, that these are cycles in political styles and actions which will come around again. California has gone, I think, to an extreme. Evidence, for example, in a good outcome, I would say, recently in Proposition 99, where the elected officials would not do what the people wanted to have done with respect to control of tobacco use. And so an initiative was passed, by no means perfect, but certainly substantially what the people wanted, 60 to 40, and now the state has to implement, and is implementing, an initiative that the people have passed, but they did it only because the people ultimately became totally frustrated mm-hmm. with the system, that there was no way of dealing with a problem like tobacco control. which is so important to health in California as well as elsewhere in the world nowadays. Well, enough of that. Let's go back to some of the
Okay, go back
earlier
to
times.
Public health
Yeah.
and your role in it.
Well,
That is the department.
the department. We did develop the Bureau of Chronic Diseases, as we called it. The tumor registry that I mentioned gave it the start, but we moved into a number of other fields. We had an interest in control of hypertension, in diabetes, and other conditions. One of the early ideas that we introduced in California was what became known as multiphasic screening. I had got the notion that in public health we were doing a lot of screening for specific diseases in the 1940s, even before that time. Surgeon General Perrin, the Public Health Service, had popularized the serologic test for syphilis, and that was applied during World War II days. Wasn't quite as good a test as we have nowadays, but it was state of the art, and it was a reasonably good test for syphilis. We also had some new gadgetry for detecting tuberculosis. Instead of having to take regular large films that people are used to for chest x-rays, we were able to reduce the size and the cost and the time involved in screening masses of people for tuberculosis. Then someone in Oxford, Massachusetts, Public Health Service supported, was able to find a way to screen people for diabetes. So we had these separate screening tests and thought that the big expense and part of this whole screening notion was getting the people assembled to come through and get the test. Of course, it was some problem to line the test up and keep the records and so on and so forth. But to manage all of that for separate diseases at different times seemed to us a rather inefficient way of going about it. So we introduced the idea of what became known as multiphasic screening. First in a factory of where cannery workers were employed in San Jose, California. The name of it came about in a rather interesting way. People have often asked me how it came to be called multiphasic screening. And I said that that term was applied before the San Jose trial of this idea, because sitting around with a colleague one day wondering what we should call this, we thought we ought to have some catchy name for it. I suddenly remembered that in Minnesota, a professor there had introduced the Minnesota Multiphasic Personality Inventory,
yes,
very well known in psychological and social medical circles. It was a personality test called the MMPI, Minnesota Multiphasic Personality Inventory. I guess it's still used.
It's still used.
And that word somehow clicked into my mind, and so we called it multiphasic screening, because it involved searching for more than one disease. Well, it was a very crude way of doing things. For example, for the diabetes testing, we had to get the blood sugar of people, and to do that, we had a gadget, perhaps 3 feet wide and 10 feet long, with a chain on the outside, in 2 places of which on the chain we would insert test tubes. And as the chain moved around, this oval apparatus, clinking, literally clinking, all of the time, various chemicals would be inserted automatically. That was pretty advanced for those days, at certain times. After 30 seconds, such and such. After 2 minutes, such and such.
But that's very innovative, considering the time.
We didn't invent it. We bought this machine. It cost relatively a lot of money for this. But it also had to go through, at one point, for several minutes, ice water. At some places it was heated, in other places somewhat cooled, and then it had to go through an ice bath. So the principal problem we had logistically with multiphasic screening was keeping enough chunks of ice around to keep that water properly cold. Well, that indicates something about the technology that we had for doing things like multiphasic screening in those days. Well, the idea took hold a bit, was adopted a little bit later by the Kaiser Permanente Medical Group, very few years later. And that happened in this way. A couple of people on the staff of the ILWU, International Longshore Warehouseman Union, led by Harry Bridges, Pacific Maritime Association, PMA, ILWU, PMA, Health and Welfare Fund had been established, and that fund provided medical care through a contract with the then just developing prepaid health plan that Kaiser had elaborated, having had experience during the war years in the shipyards and organizing medical service. So Kaiser had the notion that medical care ought to be organized. He was an industrialist.
The continuation on side B from side A, Dr. Lester Breslow.
We just flip that over. Well, Henry J. Kaiser had established this prepaid health plan. It was just getting off the ground when one of the very first large contracts was with this ILWU PMA fund. And the contract called for examinations of the men. And the story we heard was from these two women who came to see us from the staff of the fund, that when they had asked the Kaiser doctors how to schedule these physical examinations, the Kaiser doctors responded, faced with 6,000 or 8,000 of these examinations, and it would practically have overrun the plan. See, they had very little to go on in those days. How to schedule them, the doctors said, well, just send the men over, knowing very well that, you talk to people to go for medical examinations and a trickle will show up. No, the staff people said, just tell us how you want them scheduled. Well, what do you mean scheduled? Well, we'll send the men over. You see, we have gangs of 20 men who work on the ships, unloading and loading the ships. And they work on the job until it's finished. It may take 6 hours, it may take 26 hours. And then they go on a rest and they go to the bottom of the list, and then when the job comes up in time, they go back on the job. And when they're in this rest period, we'll send them over. Yeah, but they won't come, the doctor said. Well, yes, they will. How do you know they'll come? People don't do this. Well, that's part of their assignment. If they don't show up for the job, they go off the list to the bottom. And if they don't show up for the examinations, the same thing. They go off the list to the bottom. They'll come. Well, of course, then the Kaiser doctors had to have a second think. How are they going to tackle this? And while they were thinking about it, these staff people heard of what we had done in San Jose. So they came to see us to seek our help. Wouldn't that be a good way to approach this problem? At least find out whether the people have tuberculosis and syphilis and diabetes and high blood pressure, and at least do that much. And so we said, yeah, we thought that would be maybe a good way to go. Well, why don't you go over, they said, and tell the Kaiser doctors how to do this? Oh, no.
You didn't think you'd be welcome, just as they didn't expect the men to come.
So we said, no, you're in touch with the Kaiser doctors. You tell them that we're available to provide assistance. Well, we worked it out. So that Dick Weinerman, in those days, a great figure in public health, unfortunately killed in a terrible airplane crash later, too early in his career, on the Kaiser side, and I on the public health side, who was working this deal, we're trying to get the thing in place. And we had a few problems. One was that when it got right down to it, Harry Bridges, this great, bold, courageous, allegedly revolutionary labor leader, got cold feet. That maybe the men wouldn't like this scheme. And
But had the men been asked?
Not yet. It was all being negotiated by staff, including staff of the union and the Pacific Maritime, the Employers Association. So Bridges wanted us to send a postal card to the men, asking them if they would do this, would want this. And we said, no, that wouldn't be of any account, because what a person put on the postcard had little to do with what would happen when the time came. Well, Bridges said, then you have to come over and tell it to the men. So Dick and I went to the union meeting on the appointed day in the San Francisco auditorium, and at each entrance to the auditorium there were people with long rosters of names checking off. And we were, of course, admitted because we were to be on the platform. And what was all this business about the lists and the checking and so forth? The system that the union had in those days was that every member had to come to these meetings of the ILWU. If you will, that was an enforced democracy. At least they had to be in the room where the decisions were being made. And so we asked a few questions. Well, suppose you have to go to your aunt's funeral that day. Well, that's too bad. That just, you get fined $25, which in those days was a pretty... Well, suppose you're in a hospital with a broken leg. Sorry, you just have that additional $25 to pay. There is no excuse. That was the way Harry Bridges
Very arbitrary.
ran the union. So he had really good participation. So Dick and I found ourselves on this platform in front of 6,000 or 8,000 men, with Harry Bridges sitting way in the back, I remember. So we were up front making our little speeches and then answering questions. It was my first experience with microphones in the aisles of a large auditorium. There were, I guess, 6 microphones down, 3 on each of 2
But with
aisles.
8,000 people, did they actually come forward and ask questions?
They lined up very quietly and orderly behind these microphones, and a moderator would go from one microphone to the next very systematically. There must have been 30 people or more who had questions. It went on for quite a while. Not all of them were questions. Some of them were comments, cursing the medical profession and other things. But some of them were quite, many of them were really quite sensible questions. what was the meaning of all this, and why not have doctors listen to your heart and so forth. And so we had to explain what this was all about. And apparently our explanation was satisfactory because they voted overwhelmingly to go ahead with this scheme. So that's how Kaiser got started in using multiphasic screening. Well, over the years, multiphasic screening has taken a variety of forms and a good deal of criticism, justifiable, I must say, even though I was an originator of it. But it's now come down through a number of, what shall I say, evolutions to the point where at the present time, I guess the term most used for it and more related to individual evaluation rather than screening of people for particular conditions, called health risk appraisal. I guess that's a very common term. The Centers for Disease Control developed, and now the Carter Center nearby, the Centers for Disease Control in Atlanta, distributes a form of the health risk appraisal which people can fill out themselves. So many people do know their blood pressure and cholesterol level, so on, that it's possible nowadays to get some of the same idea of a multiphasic examination. A lot of people would object to my formulation of this or seeing the connection, but if you've lived through that 45 years, I could go through the detail of how it has progressed over the years to various forms, including this health risk appraisal, which individuals can take by themselves.
Well, and people are more sophisticated now about what goes on in health as far as they are concerned.
Exactly. And they're more knowledgeable about what can be done about these various things if they are found. And they are more concerned, I think, also with health as a goal, not just the avoidance of certain diseases or finding the diseases to treat them early. That's a very primitive form, which we had in the late 40s, that's all we had, of dealing with health in this new way, apart from what physicians do with you when you have particular symptoms.
It reminds me of a time when Roger Eggerberg, then Dean of Medicine at USC, came to talk to one of my social policy classes. This would have been in the 60s, late 60s, I think. And he strode up and down in his special way and announced that more had been found out about medical needs and care in the years between World War II and that year than in all of history of medicine before. And you're really referring to some of the same kind of thing.
There was tremendous technological development, and I mentioned the primitiveness of what we did in 1946 as simply to emphasize the point you just made, that there was tremendous technological development, and of course we're all benefiting from it. I wouldn't say that the technology has all been applied in the fashion that I would prefer, but at least the technology has been developed. I think I was responsible for recruiting Roger Eggerberg, you mentioned him, whom I knew as dean at USC, to be the president of the State Board of Health, to which post he was appointed by Pat Brown. Well, I should mention one other thing early on. In 1952, before this air pollution thing started, 1952, as Chief of the Bureau of Chronic Diseases. That was my title in those days. I received a telephone call from Russell Lee. Russell Lee was very well known in California in those days and throughout the country for having developed the Palo Alto Medical Clinic. He also had several famous sons, including Pete Lee at USC and Phil Lee now at San Francisco, and two other sons and a daughter, all of whom were in medicine, have been in medicine. Phil Lee, Russell Lee, called me up, asked me to come down and see him. Well, that was a great honor, so of course I went down there. He told me then that he was a member of the Truman Health Commission, 1952, fairly early in the year, that the commission was obligated to make a report to Truman before the end of the calendar year, that he and a couple of other members of the commission, including Lowell Reed, who was then either the dean or became the president of Johns Hopkins. He'd been the dean of public health and became president of Hopkins University. And another man who was the head of the Machinists Union in those days. Three of the dozen or so members were dissatisfied with the choice made by the chairman of the commission for a study director or staff leader. So the three of them had decided that I should be the staff leader, and since Russ Lee was the closest to me, he was given the charge to recruit me. Well, I was immensely flattered, but explained to him the several reasons why it was utterly out of the question. Number one, I was working for the State Board of Health, State Department of Health, and the department or the board would give me leave for a whole year to go off on some federal deal. Number two, I had a family, young children, and no way that I could pick them up and move them to Washington and all of that. And I wanted to see them, and so on. And another was that while I wasn't getting a lot in the State Department of Health, this job didn't pay enough, and they'd have to give me, of course, leave without salary from the department. It wasn't going to pay enough for me to keep even any kind of an apartment in Washington and still keep my family in Berkeley. Another was that just at the time of the end of the year, when they would be getting the report ready, I was going to be at the American Public Health Association meeting. I was determined to be a public health professional, and I had to be at that meeting. Well, I gave these several reasons to Russ Lee, and he had a little envelope he was writing down the back of the envelope. So we parted very amicably. About 10 days later, he called me up, wanted me to come down and see him. Well, what about this time? Well, you want to talk some more about the job? Well, we talked about that, and it was just not feasible. No, I think it could be worked out. You have to come down and see me. It's very important. So I did. He had that same envelope. The first thing he handed me was a letter from the president of the State Board of Health granting my leave for the year. The next thing he handed me was a set of travel requests. You may remember that in the olden times, the federal government didn't pay your way. They gave you a so-called travel request, and you signed it and to some machinery, and then you got the ticket. But you got those for a particular assignment. You probably had several of those in the years. He handed me not one of those, but a whole book. There were, 25 or more in that book. And he said he understood about families. And whenever I wanted to see my family, any day of the week, that I just go down to the airport and turn on these tickets in and go and see my family.
That was really an unusual.
Then on the salary, he had a contract which she said, it's true they don't pay very much, but this job you're going to have to work not 5 days a week, but 7 days a week. And some super salary, 7 days a week, it's going to cover things for you. And that was true. Now about this American Public Health meeting. That week, I'll personally go back and sit at your desk.
They really wanted you.
So, faced with all of that, I, of course, did go back and spend about 10 months on that assignment. And we wrote a report called Building America's Health. Truman had wanted that because, like Earl Warren in California, Truman nationally wanted to do something about health, felt totally frustrated during his years succeeding Roosevelt and after his own election in 1948, and so decided he would have at least a commission report. Well, the commission report came to Eisenhower's desk. In fact, there is somewhere a picture of this being on the desk when Eisenhower walked in to be president. In any event, nothing ever came of the report, although I still use it from time to time, because some of the ideas that we advanced are only now beginning to get some attention. Very few people know about even the existence of that report.
But it suggests that there is always a time.
That's right. And there are always, or there are often, shall I say, political people like Warren and like Truman who have a sense of what needs to be done, but are totally frustrated in getting the political wherewithal to get the programs through. There are times, of course, and Roosevelt and Social Security is perhaps the outstanding example of this century in this country. Bismarck in another century in another part of the world, likewise, and for different political motivations perhaps, accomplished some forward-moving health and welfare goals. So those were quite frustrating, although very interesting experiences. And you're quite right, I think, that not only must they be good ideas to meet real needs, challenges, but they also must be timely with respect to public understanding and the possibility of public commitment.
Do you have available a copy of that commission report?
Well, I've got a personal one at home, but that's about all. There are not very many around. This came out in 4 volumes. The first volume was a summary, and I used it not infrequently to indicate one of the most modern things, and one to which I'm now heavily committed, and that is health promotion. But the formulation of health promotion in that report, I think, is still a very good one. I didn't invent it, let me assure you. I took it from Henry Segerist, whose ideas about health and what to do about it were extremely influential in the minds of many of us who were on the left in the health movement in the 40s and 50s. So we didn't give Segerist credit for that. I'm sure he wasn't looking for the credit. But the whole report is based on Segerist's concept of health, which begins with health promotion. And we even dealt with the issue of the relationship between individual and social or community endeavor for health, which has become, as you know, quite prominent in debates over the past decade or so about health, what to do about it, who's responsible for it, and the like. I feel the formulation in that commission report, which we took from Segerest, we didn't quote him and we didn't use his exact words, but it was
But he's getting credit today.
Today, in this interview,
it's on record.
On record. Well, it's no secret to anybody that, or any scholars in the field, or anybody who knows about the concepts of what to do about health, the contributions of Segerest to thinking about health in this country have permeated all of my work over the years, and the work of many, many people in the public health field. Yet, although he's known to scholars, and especially in the history of medicine, which was his particular point of scholarship, he's not very much known in public or even professional circles. My guess, if you asked the faculties or student bodies of medical schools in this country, with the possible exception of Hopkins, which is where Segerest was a figure for many decades, even there, I suspect that not very many people would know what Segerest did. Not very many people would even know his name. But he deserves a lot of credit. Well, now let's see.
Well, you brought me up to Merrill being the director.
Yes.
And
Merrill was a director, and for those interested in state-county government relations, a contribution made by Malcolm Merrill may be of considerable interest. Merrill had come into the California Department of Public Health before Halverson did. Merrill came in during the late 1930s.
I didn't realize that.
He was a laboratory person, and he developed a laboratory service. He also was especially interested in venereal diseases. When Halverson became the director, appointed by Warren, selected by Warren after a very careful search, Halverson brought Merrill in. He'd already in the department. He found him there to organize and lead the laboratory services, which Merrill did at the beginning of Halverson's career. And when I entered in the department in 1946, that was still part of Merrill's responsibility. But Halverson drew him in quite quickly as his deputy, so that Merrill became the Deputy Commissioner of Public Health. Both of those men, by the way, Halverson first and Merrill later, and the succeeding Director of Public Health, over the period of what I call the Warren-influenced era, from early 1940s to the late 1960s, 25 years of public health work. There were only 3 directors of public health, and all of them, for whatever it may mean, were presidents of the American Public Health Association. So California really was a leader, and Halverson and Merrill really set that pattern. Merrill then was the deputy of the department and was well trained in some aspects of public health, but principally in the laboratory side. So he decided that he should get broader training in public health. He went to the Berkeley School of Public Health, got a degree, going part-time and over, I suppose, a few years. And his thesis, I'm not sure he got a doctoral degree, but his thesis was that the state should enter into partnership with the counties in California to advance public health. And he had certain very concrete notions of how that partnership should be effected and carried out. And two of the essential ideas were that there should be a state subsidy to county departments of public health, enough to make it worthwhile to get the subsidy, and to do so, the counties would have to meet a certain standard, that they had to have a certain standard of public health service, personnel and service and such requirements. Further, that the counties should organize themselves and, as their health officers, leaders, become a conference of local health officers that should advise the state, have virtual veto power. I'm not quite sure whether they had actual or literal veto power, but it had to be by consensus between the state and the counties represented by this California Conference of Local Health Officers, CCLHO. Well, that was Merrill's idea, which he developed as a student, of course, a mature public health person already, but in that capacity as a student. He not only developed it as a thesis, but in the department he carried it out. Halverson saw the merit of it, and the two of them persuaded Earl Warren that it was a good idea. The legislature saw the merit of it, and it became law in California. The legislature, of course, had to appropriate the funds and otherwise create the statutory environment.
Did that then involve the local county departments carrying out certain specific functions that had been carried by the state?
No, not really. What it did was to standardize, if you will, not in the sense of standardizing to some point of mediocrity, but having a certain minimum standard, standardized in that sense, of service, such as they would have to have a maternal and child health service, and they would have to have various other features of a reasonable local health department.
To me, that's especially interesting because that parallels the pattern that came into public welfare when the Social Security Act was established, and the relationship between state and county operations. It has some of the same
flavor.
Yeah.
That's right. And Merrill and Halverson, but Merrill took the lead in this particular thing. This was when he was deputy of the department. And they carried that through, and it had a tremendous influence on the course of public health work in California. It was later largely undone in a way that we can perhaps talk about a little bit later. But it was a profound contribution, and I think that still, when we get our politics a little bit better under control in California and elsewhere in this country, that it is a pattern that might be considered again, I'm sure, in some different format and so on. Of course, there are people who would insist that it exists to the present time, but not the way it was originally established or intended. So Merrill was, again, a great leader in public health. Both these were really very fine men. Halverson was a Seventh-day Adventist. I think I mentioned that.
Mm-hmm.
Merrill was a Mormon. And their own lives were lived not with any extreme rigidity, following those particular faiths and their doctrines, but quite well, I guess. They were both certainly very well known and accepted in their respective circles. So it was rather interesting to me that they had these religious notions. They were both quite conservative politically. I don't know, but I certainly presume that they both voted Republican every election of their lives. I may have been wrong, but that was certainly my assumption. And they knew very well that I never voted Republican. Well, I'm not certain about that. I can't remember when I ever voted Republican. So that they had that toleration for somebody who would work in the environment that they established for public health in the state. I recall one instance, going back to Halverson for a minute, that will illustrate their way of expressing their convictions. Halverson asked, because I was in those very early days interested in tobacco use control. We did some of the early studies in California. Several of the studies that constituted the basis for the Surgeon General's report on tobacco and health. The report in 1964 that was really the watershed nationally and in the world on tobacco use control. Utilized the work, a lot of other work of course too, but some of the work that we had done in California, which we started in the very early days, in the late 1940s. So Halverson knew about that and my interest and so forth. Well, that of course was quite consistent with Loma Linda University and their views of health. They had a medical school and a school of public health. So Halverson induced me to go down and talk with those people. They invited me to come to their annual alumni meeting. They'd bring in graduates with people on the campus, faculty and students, and they would have a weekend or so of discussions. So on one occasion, early on, Halverson went with me. He was on the platform behind me as I spoke about some of these matters, and at the end of my talk, maybe 100 people there, one man got up and began really attacking my point of view, which was that we should encourage people not to smoke, that we needed to do things in society to change the conditions in which people learned and kept on smoking, and so on, that you might expect. And a few other things about alcohol and the like. Although I did not favor, still do not favor necessarily abstinence from alcohol like we favor absolute abstinence from tobacco. I think they're really different things, and that's pretty generally accepted. In any event, a gentleman got up and lambasted me. The principal notion being that the people who used tobacco or alcohol were essentially sinners, and that that was the way to tackle the issue. Enough of this medicine and health education. These people were to be blamed. And I was getting a little bit fidgety, wondering how I was going to deal with that issue. Halverson came up from the back of the platform that came up that he more or less pushed me aside from the rostrum. And he took after this fellow in a public meeting, like I have rarely seen anybody attacked in public. The upshot of Halverson's remark was, "You're a doctor. Now, when the poor patient gets typhoid fever, how do you deal with him? This way?" And he went on to really let this fellow have it, that religion was one thing, but medicine and health were something else, and that we shouldn't mix them up.
And probably nobody else could have done that.
Except Halverson.
Uh-huh.
So I mention this to indicate his forthrightness and ability to seize hold of what he thought was an important issue. The only difference between us was that we didn't agree on what all of the important issues were. And he knew very well my role, for example, in forming the medical care section of the American Public Health Association, even during the time that he was a leader of the association, and bitterly, I don't mean mildly, bitterly opposed to it. Merrill was much milder in his approach to the matter. Well, during those days, when I was chief of the Bureau of Chronic Diseases, it was necessary to develop relationships with the voluntary health agencies, with the American Cancer Society, American Heart Association, American Lung Association, and so on. Those days it was the NTA, the National Tuberculosis Association. And there were groups forming, Crippled Children's Society, and Diabetes Association, and so on. And they were obviously a very important element in public health. The government wasn't going to be able to do everything. Probably in our society should not try to do everything. But we needed to cultivate popular public, not only interest, but participation in the development of services, including education, but other more direct services to people. So that I regarded the voluntary health agencies as extremely important partners with government, state government. And of course, as we were developing it with county government in California for public health. And seeing that interest and attitude, these agencies would often invite me to serve on committees or councils or boards, so forth. So I was quite active in some of those voluntary health agencies. In the American Cancer Society, for example, being on the national board for a while. In fact, chairman of the Committee on Etiology of Cancer, which I thought was a bit bizarre even in those decades, some decades ago, when I had that responsibility. But nowadays, even more bizarre, considering the nature of cancer research and the way it has become so, I would say, distorted towards the so-called basic medical science approach to cancer, without sufficient emphasis on the epidemiologic aspect of cancer. When the most important things we've learned about how to control cancer have come from epidemiology. There was a glimmer of a grasp of that notion a few decades ago in the American Cancer Society and elsewhere, but it's been too largely snuffed out, hopefully to recur. And I wouldn't say it's been totally snuffed out, but certainly has not been given the support over the years that other aspects of cancer research has been given. Well, that's a sidelight on this notion. You may recall I worked with you and other people in the study of cancer needs of patients in California. That must have been in the early...
That's when we first met.
That was when we first met. That must have been in the early 1950s or sometime.
Around 1957.
Okay, late 1950s. So I was very close to those associations. I had one perhaps funny trouble with them, and that is that there were so many of them, and I would have to go to visit them at semi-annual or annual meetings or whatever, that of course couldn't keep track of the boards or the council or the committees or the people that I had met 6 months ago. And of course, being from the government and therefore a kind of a special creature, they would remember me, but I had a hard time remembering them. I had a very good secretary in many, many ways, a Japanese woman whose family had been in the camps, carted off there by Earl Warren, and one of the things that he wrongly did, in my opinion, in the early war years. She herself had been an interpreter for the Army, had escaped the camps, but her family had been in those camps. In any event, she came to work in the department, and she was a wonderful woman. She would keep a roster of all of these organizations and all of the names of the people and who had just been elected the president or chairman or this or that. And so just at 11:30, when I was leaving to go to the luncheon, she would hand me this list.
What marvelous service.
She was terrific. Otherwise, I would have been a terrible...
Well, I can imagine with yours the only department of its kind, how important it would seem to all these organizations to have you.
Yeah.
And when they're set up like the Cancer Society, I think they then had 33 branches around
like
the
that.
state.
Yeah. Well, I met some marvelous people, including Francis Feldman. Others too. One man stands out in my mind, however. That was Larry Arnstein, Lawrence Arnstein.
Oh, yes.
Larry Arnstein was a fur merchant in San Francisco who retired early. I think he was only 55, in quite modest circumstances. He wasn't wealthy. He always lived in a very modest house and a very modest lifestyle. When he retired, he went to see a few people to inquire what he should do now. He wanted to devote himself to good works. So one of the people that he saw was Bill Shepard, then the medical chief, not sure of the title, of the Metropolitan Life Association, insurance company, whose office was in San Francisco. Laurie went to see him. Bill Shepard said, "Larry, you should enter the voluntary health agency movement. And I've got just the job for you. And that's to be the executive of the American Social Hygiene Association." Well, you smile, Francis, but whoever listens to this will not know, probably, that the American Social Hygiene Association was a euphemism for the Anti-Venereal Disease Association, concerned principally with syphilis and gonorrhea. So Larry was in this job, the executive of the American Social Hygiene Association. I never did know whether they paid him anything.
I think not. I think it was his expenses were covered, but that was all.
He worked, however, full-time, not only for the American Social Hygiene Association, but for every other aspect of health and welfare in the state. Beginning at age 55, he knew nothing about this field except to...
Number one with Dr. Lester Breslow.
Larry Einstein was probably the greatest volunteer in the health and welfare movement that I have ever known. I've known some other marvelous people, including one of my own colleagues here right now, and others over the years. But Larry was something exceptional. He worked across the whole field of health and welfare. To him, there was no division. He couldn't understand the difference between welfare and public health. For example, he worked for Crippled Children Services. I don't think he ever had a position with the agency, but that was one of his very special interests. I guess he worked more in close connection with the health department than he did with welfare agencies. But he really was a marvelous figure in California. And he did a lot of great things. He was utterly selfless and very careful in what he did, depending on expert advice, never presumed to be a professional in the field, only a volunteer who would try to find what the expert consensus was on a topic, and then if he felt it was important, he would see it through. And he did a lot of great things, was very effective in Sacramento because people knew that he had no self-interest. He was the most utterly selfless person I think I have ever known. And he was also careful, so the legislators knew that what he said they could rely on. And he ranged across the whole field. People knew that he would show up whenever there was an important issue in health and welfare, in Sacramento or in the offices of some legislator or whatever. I learned two things from him, which I've never been able to follow, I must confess, Francis. But his was the ideal. And I've often thought about, I wish I could be like Larry Einstein. One thing he taught me was never have a meeting, never call a meeting, unless you know not only what is going to happen, but who is going to say what at the meeting.
Good community organizer.
So he would think, and he could call any meeting he wanted to. Anybody would come to a meeting that he called. He had that respect in the community. That if he called a meeting, it was for something significant. But he would call a meeting only when he decided what the issue was, that something could be done about it. He would never call useless meetings, only if he thought there was a good opportunity in assembling a certain group of people, whom he would carefully select. And then he would visit each one, both to ascertain what their views were, and I suppose some might not have been included, whatever. But he would not just keep people that agreed with him. He would really try to find what the range and what the consensus is and to get the full body of expert opinion. Not only to find out what they thought, but I suppose insert some of his own notions. And then he would call the meeting.
But he would have done most of the work
Ahead of time. I don't think very many people call meetings or participate in them that way nowadays.
No, I think that's unfortunately true.
I had another mentor in public health who had a different approach to meetings. That was the first person for whom I worked. He was the health officer. That was Chesley, Albert Chesley, who was the health commissioner of Minnesota. I spent a few years in the Minnesota Department of Health before going into the Army. and then, as I said, coming on to California. Shefty's idea of a meeting was to let other people call it. He would only go to meetings that other people arranged. Then if he didn't like the meeting, his pattern, and I saw this several times, would be to arrive late after the meeting had been started and in the doldrums or sputtering for half an hour or so. He would arrive with a stuffed briefcase. He usually carried around such a one. And then in the midst of the meeting, he would, as he came in, be taking something out of his briefcase, some document or paper, which he would hand to this person. And then he would see somebody else over there. He would have another paper, apparently not a copy, but some other document. He would do this to 2 or 3 people. Then he would grab the document away from the first person to whom he'd given it and pass it over to somebody else. So he would be sort of standing up in the meeting, crisscrossing and passing around all of these documents, and not saying a word or paying any attention to what was going on.
Really operating the meeting.
And completely dominating the situation and disrupting the meeting. I mean, whoever had called it no longer could do anything. Well, those are 2 ways of operating in meetings that I had mentors for. But I must say Larry's notion was somewhat more appealing. While I'm on that subject of running, let me digress once more to mention what Lowell Reed taught me during those years when I was months. 1 year, 1952, when I was working with the Truman Health Commission as study director. We had some wonderful people there, both on the commission and the staff, who went on to great things. When I began to write the reports, draft reports and so forth, minutes, Reed said, the most important thing in convincing people on a commission like this of the correctness of the document that you write. I see, he said, that you're writing documents and that you have some of your own ideas. It's fine. But the way to convince the people is to take some of the exact words that they use in their discussion and put those words into the report. You can find a way to do that. It doesn't have to be on your most important points, but you find a way for getting the precise words that the various members
so they
use.
recognize themselves.
They, even though they don't recollect maybe consciously about this, they get a sense that, this is just right.
That's a very interesting strategy.
I've used that all my life. I use it today. I use it with staff people here, and with everybody. It's the best tool that I have ever encountered for convincing people in a group of what to do. Just listen very carefully to what they say, and they all will have some ideas and say it just right, that you can fit it into the report. If you can't do that, then you're not doing a very good job. If you write the whole thing totally separate out of your own mind, not paying any attention, literally, to what they have said, obviously there's going to be trouble.
It's not part of them anymore.
Not part of them. So anyway, that's a little tool that may be useful to some people. But coming back to Larry Arnstein, he taught me, as I've told you, his idea of how to organize a meeting, and he did it over and over again that I saw. He taught me one other thing. He told me several times, maybe because he saw the need for it. He said, Lester, you can accomplish anything in public health, provided you really don't care who gets the credit. That's a pretty hard lesson.
Yes, it is, in any field.
Any field, to learn. But he had learned it, he practiced it. And while I've never encountered anybody that approached him in the ideal lengths to which he went to carry out this notion, I think it's a very good lesson. And a lot of the failures in public health, I don't know about welfare, but certainly in public health, have been, in my opinion, in considerable part attributable to difficulties over credit.
Oh, I think it's equally true in the welfare field. All aspects of it.
Right. Well, I don't know.
Go ahead.
Yes, go ahead.
No, I was going to say maybe this would be a good stopping point.
Okay.
And only if you set another time.
Okay. We can talk about that. Yeah, I think it is, because that brings us to 1960 more or less. And the rest of it we might cover in a...
Yes, but what you have not dealt with yet is when you became the director.
Well, that was later, so that was in the 1960s.
So we'll pick that up.
Well, we'll pick it up at 1960 when Pat Brown became... How's that?
All right, that's good. But that doesn't mean you can't include other things, because California is with the rest of the world.
We're 1/10 of the United States, at least.
You were talking about the Department of Public Health when we left off.
Right.
You had become the director, the chief of the Division of Preventive Medical Services.
Right.
Now, considering that the health officer, when you came, really wasn't interested in prevention, how did you get that in?
Well, as a matter of fact, the health officer was interested in prevention, as he would define it, and that was limited largely to control of the communicable diseases and difficulties in maternal and child health. He was in favor of prevention in those aspects of public health. What I tried to say, I think last time, was that he was not at all interested in chronic disease control, including the prevention of chronic diseases. In that period, that is when I first encountered him in 1946, he, of course, was in the mainstream of public health, which had not up to that time given any attention, any substantial attention anyway, to the potential for the prevention of the chronic diseases or for their control, and particularly did not have any sense that they should be included in the framework of public health. But by 1960, when I had already been chief of the Bureau of Chronic Diseases, as they called it in those days, for 14 years, and along with others across the country, had begun to cultivate the field, public health approaches to chronic disease, there was beginning to be some recognition that possibly it belonged in public health. But by that time, also 1960, of course, that first health officer whom I mentioned last time, Dr. Alberson, had died, and his successor, Malcolm Merrill, had been the leader of the department for 15 years or so, and had invited me to become the chief of the Division of Preventive Medical Services in the department in 1960. Pat Brown had, by the way, the division at that time included not just the Bureau of Chronic Diseases, but all of the other medical bureaus in the department, those devoted to maternal and child health, communicable diseases, occupational health,
they were all in
crippled children.
chronic.
They were all in the Division of Preventive Medical Services. So I moved from being a bureau chief, which was the hierarchically lower unit, to the division, which was the higher unit. And that brought me into what you might call the cabinet of the department, which consisted of the 5 or sometimes 6 division chiefs. So we would meet quite frequently with the director and with the other division chiefs. It was a wonderful department, a great experience, and really a great joy. I was happy that they paid me for it too. It was such a pleasure to work there. Well, I started to mention, I think, that Pat Brown had become governor by that time. He was very interested in the progressive aspects of public health, including medical care. He had a substantial interest in medical care, and in fact renewed in a very important sense what Earl Warren had started 20 years before and had been unsuccessful in carrying through all that he wanted before he was appointed to the Supreme Court. And during the intervening years in the middle and late 50s, not very much had been done by Goodwin Knight, the Republican successor to Earl Warren. But Pat Brown had renewed that progressive spirit in public health and a lot of other aspects of
and
state
mental
government.
Health. Those
mental
three
health,
were very involved in that.
And welfare. And brought in some very good people to state service as heads of departments. Among the things that he did, for example, was to initiate a program of medical services as a part of the public employees retirement system. That covered all state employees. And the program was essentially the same that had been introduced for the federal government employees. It provided that employees could select a health care plan in a very progressive manner, comparable to that of the situation in the best private employment situations. He linked it to the public employees retirement system for reasons of administrative control. The Board of Administration was given of that employment, of that retirement system. The Board of Administration was given responsibility for administering the health program. It provided, as I say, opportunity for employees to select for themselves and their families. Really quite good programs. Brown appointed me to be a member of that board at the beginning of this new program in 1960. He did so because he wanted somebody that he regarded as well-suited medically, who was close to, as a matter of fact, in a state government that I suppose would be carrying out his general philosophy in that program. The administrative board of administration, appointed 3 people. As a matter of fact, Brown appointed 3 new people to the board in accordance with the legislation these three new people to have a special responsibility, but within the framework of the entire board, for decisions about this new program. The board did defer really quite substantially to the recommendations that the three of us would make. And since the other two were non-health professionals, although interested in this topic, they turned to me quite a bit for recommendations on the implementation of this new program. That was a very interesting responsibility, because we had the opportunity there to really inaugurate something that in a sense established a kind of a pattern, not just for public employees in the state, but also to some extent for private employees who looked to the model that the government would establish for its own personnel. The principal decision was to determine which of the health maintenance organizations, or as we called them in those days, prepaid health plans, would be admitted to participation. Of course, the Blue Cross Blue Shield plans were included. A major private insurance company was included. But the real question was which of the many health maintenance organizations or prepaid health plans in those days would be admitted. There were a lot of upstart organizations, prepaid health plans in those days, that had followed on the success of the...
These would be like Ross-Luce and Kaiser.
Correct. Now those were the two
main
Ross-Luce and the Kaiser were the longest established. The Ross-Luce clinic going back way into the 30s, and the Kaiser prepaid health plan having been started immediately after the end of World War II, based on Kaiser's experience with industrial employees. He converted it to a prepaid health plan. Those two were clearly going to be admissible, and they were admitted at the very outset. Then the question was how to deal with these many others that had tried to copy, in a way, what Ross-Luce and Kaiser had been doing. By that time, Kaiser was the predominant organization in the field. So we had quite a struggle to hold down the participation of other organizations, because many of them were really quite poor. Gradually, some of them, good ones, have been admitted to participation. One at least admitted during the period that I served on the board during those early years. But that did set a pattern for quality of work in state government, and was typical of what Pat Brown and the then quite progressive legislature wanted to have for the state. So that was quite a bit of fun. There were other bodies established. Pat Brown appointed a commission on medical services, just as Truman, I mentioned last time, had such a commission in the early 1950s. So Brown appointed one in the 1960s. And again, I had the opportunity to serve as the study director in effect of that particular investigation. During that period of the 60s, we also continued with things that had been started and which I believe I mentioned last time, namely air pollution control. By the time that Brown came in and John Maga and I in the department had done the work, I think, which I described last time, and the State Board of Health had approved the regulations for standards of the ambient air and for automobile exhaust. There was established an Air Resources Board, I think they called it, in which again, an effort was made to maintain quality of scientific work in approaching the air pollution problem. While these things were going on, of course, things began to happen in California and elsewhere during the 1960s. And by the middle 1960s, there was a very strong social movement in the inner cities, especially led by black people. You may recall, and I'm sure you'll have otherwise described in your series of tapes here, the so-called Watts Riots of 1965.
I worked in that, so I know it.
So you know it quite well, okay. Then I don't have to give you any detail about it. But there was one thing that came to the department of considerable interest. In 1965, immediately after the so-called riots, I had been, perhaps I should back up here and make clear that I served as the chief of the Division of Preventive Medical Services from 1960 to 1965. In the latter year, Malcolm Merrill, who had been the director of the department during the Brown administration and a bit before, I think, left to head the medical aspect of AID in Washington, D.C.
Not today's AIDS.
No, not today's AIDS. This is Agency for International Development, an agency of the federal government for allocation of certain funds that the Congress appropriates for international assistance, principally economic, but to some extent social, and also there was a medical component, which Malcolm Merrill went back at that time to head. That left an unfinished term, to which Pat Brown appointed me. So I became the director of public health in 1965. That was the year, you'll recall, when the riots took place during the summer. And I won't need to describe them here because you'll otherwise cover that. You may recall that a commission headed by McCone, called the McCone Commission, investigated the matter at the initiative, I think, of the governor.
Yes.
The McCone Commission came in with a report which advocated the development of health services in the Watts area, as it's come to be called, although it covers a great deal more of Los Angeles, a whole segment, not rectangular segment, in the very middle of south central Los Angeles. The McCone Commission, in recommending those health services, I think specified a hospital to be developed there. At least that came to be quite an important aspect. Sherm Mellenkopf, who was the dean of the medical school, who was, I believe, a member of the McCone Commission.
Yes, he was at UCLA Medical
Correct.
School.
Sherm Mellenkopf, the dean of the UCLA Medical School, a member of the McCone Commission, had been, of course, an important party to that part of the McCone Commission report. After the report was submitted, perhaps even before, Mellenkopf called on a member of the faculty of the School of Public Health, Milton Romer, to participate in the investigation which led to the recommendations specifically for a hospital in the Watts area. Well, that recommendation in very early fall of 1965 came, of course, to the State Department of Public Health, of which I was then the director. So I called in, as the first step, the people who were responsible in the department for the hospital planning and construction program. Some decades before, in the 1940s, I believe, the Congress had established a program in which federal funds were given on a matching basis to states for hospital construction. That program was started by two congressmen, Hill and Burton, Senator Hill and Representative Burton. Or were they both senators?
Burton. Burton was a representative from California.
From California. Well, I'm not sure it was that Burton.
Oh, no, this was the Burton from New York, and predated
the Burtons of California. Yes, you have to keep these eras separate.
In the late 40s.
Correct, the late 40s. The Hill-Burton program allocated funds to the states because it was recognized that we were way behind in hospital construction in the late 40s. And that program was still going in the middle 1960s. And the implementation in California called for the funds to be 1/3 federal, 1/3 state, that is state appropriations, and 1/3 local, which could be either public or private nonprofit. Of course, the funds would not go to any proprietary hospitals. So, with that program in mind, and with our planning for it having gone on with the advice of a body of citizens representing various segments of California society, it was obvious that the thing to do was to see how that program related to this particular recommendation. Now, the data came in to me, and the staff first pointed out that every area of the state was equitably being covered. When we looked specifically at the Watts area, which is that rectangular piece in the middle of south central Los Angeles, it was a fascinating document because there were, in fact, hospitals on the periphery of that rectangle. Not all the best hospitals, although there were some reasonably good hospitals outside the area and with some regional proximity to that area. But within the area, there were no hospitals, 0 hospitals in this huge rectangular piece of south central Los Angeles. What had happened, of course, was that that area had been, as the politicians would say, gerrymandered. So each of those pieces was, the rectangle was quartered off so that each of the pieces were attached to adjoining larger areas, in which large areas there was a hospital. So looking at the lines as they were drawn at that time, yes, that area was as equitably covered as any other part of the state. But the people in Watts talked about saying they were $10 sick when they had to go to the hospital, because to them the hospital was not any of those adjacent hospitals where they were not admitted, but rather to them the hospital was what we now call the USC, Los Angeles County Medical Center.
With no means of getting there.
No means of getting there. The bus traffic, I think, took 3 or 4 changes. So when they said $10 sick, that meant a $10 taxi cab ride. And $10 was quite a bit of money, especially in those days. Well, it seemed to me that that was not really an equitable distribution of hospital services. So I asked for a pencil, and we began drawing some new lines. We created a new hospital district right then and there. But I would emphasize that we did so not on our own initiative, which I wished we had been able to do, but rather in response to the fact that a bunch of young people went out on the street, and a lot of them got killed because they were seeking reasonable rights for themselves and their families. Well, some of us felt very strongly about that situation. So it didn't take very much effort to get appropriate approvals of the State Hospital Council, which was the planning body, and I think we also needed approval of the State Board of Health to make a rather quick adjustment on the map for allocation of funds for hospital services. So we did that quite promptly in 1965 in response to the McCone Commission report and what Mellenkopf and Romer had found would be at least one way to deal with the problems of that part of Los Angeles. So we announced then that there was a new hospital district with 0 hospitals. So that immediately went to the top of the list for allocation of federal and state funds, 2/3 of the amount necessary to build a hospital. The question then was, where were the local funds to come from? The first initiative came from a very enterprising, I would say entrepreneurially oriented physician in Los Angeles, a Dr. White, who proposed that he would organize the hospital. It was never entirely clear, however, that it would really, in the long term, be a non-profit, voluntary hospital, as we called it in those days. It also seemed that he and the few people that he had with him were not adequate to the task of organizing, building, and operating a hospital of the kind that was obviously necessary for these many, many tens of thousands of people. So, not very much later, a request came from the Los Angeles County Board of Supervisors, which was initiated and led by Kenny Hahn, then and still a supervisor. So Kenny Hahn took the lead in getting Los Angeles County to apply and, of course, to agree to put up the monies. And that was the way it turned out to have built in Los Angeles the Drew Medical Center, or as it's now called, the King Drew Medical Center. The hospital was named for Martin Luther King, and the medical school affiliated with it for Charles Drew, the eminent black physician. And it would be, and has been, a county facility with a medical school as a part of the enterprise. So that's how we now come to have the King Drew Hospital. That's been a very interesting development over the years. The academic arm of it has evolved into a Medical and Science University, still named, of course, for Charles Drew. It has in it now not only the School of Medicine, but also a School of Allied Health, and I'm not certain about other schools. The medical school at the outset was sponsored in part by both USC and UCLA medical schools, and there was strong participation by the deans of those two schools and by members of the faculty to help build up the faculty at the Drew Medical School. Over the years, it has become more of a UCLA affiliate because the academic program, the selection and teaching of undergraduate medical students has been, for the Drew, a joint enterprise with UCLA. That turned out to be the only way in which they could get state approval for funding the school, and also for getting approval to turn out doctors of medicine from the Drew Medical School. So it continues to be strongly affiliated now with UCLA. I don't think that USC participates so much or even at all.
No, I think it's diminished some, but
still has some attachments.
Yeah.
I know that the current dean and I know several faculty at USC have substantial interests at the Drew and in South Central Los Angeles generally. So I know it's still supported, but the legal thing had to be switched to UCLA. Well, that was one of the more interesting features of the middle 1960s. Then in 1966, we had a very interesting campaign for the governorship in California. Pat Brown was running for his third term, and on the Democrat ticket, and Ronald Reagan had been selected by a coterie of Republicans with strong political influence and a lot of money to become the candidate for governor. And of course, in that election, in the fall of 1966, Reagan was elected. That had tremendous repercussions on health and welfare in California, and I'm sure that you and others will be recording what happened on the welfare side, but I can mention a few things perhaps on the health side that may be of interest. I'll have to personalize it a little bit because that's the way I think of it.
That's why you're the one who's being, quote, interviewed, unquote.
Reagan came into office as an arch conservative. I'm sure that even he would have to accept that term. And the people surrounding him were determined to break the tradition of California of progressive state government that had been established by Earl Warren and carried forward by Pat Brown. That was very clearly the campaign, the determination of the incoming Reagan administration. And you may recall that to be sure this happened fully, Reagan took office ostentatiously at 1 minute after midnight of January 1967, when he was officially the governor. He did a lot of things during those early months of his administration. So far as public health was concerned, and the Department of Public Health, he sent, or at least allowed, his lieutenants to come to the department to ask for my resignation. I had been appointed to fill out the unexpired term of Malcolm Merrill. You may recall that by arrangement established by Earl Warren and Halverson as the Director of Public Health, appointed by Warren in the early 1940s, the Director of Public Health was an unusual position in state government because although appointed by the governor, the term overlapped an incoming governor by 1 year. The idea being that the governor and the Director of Public Health would get used to one another and want to continue. That way, the governor could make an appointment based not on politics, but on qualifications for the technical job that had to be done. That was Warren's idea, and that prevailed until Reagan came into office. And we had been through Republican and Democrat administrations, and that principle prevailed for those 25 years. But when Reagan came in early 1967, he and or his lieutenants decided that they wanted a different arrangement. So they asked me to Ronaldo Batista.
This is side B of cassette number 2 with a continuation by Dr. Breslow.
I was starting to tell you about the first steps that Reagan took regarding the Department of Public Health. It didn't come very high, I'm sure, on their priority list, but I subsequently learned that a group of physicians centered in Kern County had been adamant in the support of Reagan as the candidate for governor that he would do something to the Department of Public Health, put it that way. I was no longer eager to continue as the Director of Public Health to complete the term even, because I was no more happy to be serving in the Reagan administration, which had already made clear its colors, than they were to have me. But I advised the people who came to see me that while that was true, I was no longer eager to serve, as they were not anxious to have me serve, that this was a term, and that some of the major parties of interest ought to be consulted, and that I would do that. So I consulted the public health officer leadership, the California Medical Association and California Hospital Association leadership, to ascertain their views on the matter. All of them insisted strongly that I should complete the term. That was true even though in the course of public health work one has sometimes to come into conflict with the medical and hospital worlds. And I had done so. But they still insisted that this principle was very important to public health in California, and therefore, along with the health officers whom I consulted, they insisted that I should stay on and not accept this demand from the Reagan administration to leave. When I reported that, quite firmly, the Reagan people backed off. Meanwhile, they appointed a man named Spencer Williams to be the head of Health and Welfare Agency. That was the cabinet post to which the Department of Public Health reported. So,
and social welfare and mental health.
correct. So Spencer Williams was my boss, so to speak. I did not have anything to do, I didn't have much to do with any others in the Reagan administration. Spencer Williams and I got along quite well. In fact, in a few months, by early fall of 1967, he was going about the state praising the department, and me in particular, and proposing that I be reappointed the next term. Hold on a secretary, just awfully.
So Spencer Williams wanted you reappointed.
Right. I talked with him and remonstrated, in fact, that that wasn't going to happen. It didn't take any political insight to realize that was not going to happen, and that he wasn't doing me any good, and he wasn't doing himself any good by making such proposals. But he didn't back off very much. I don't know what he did in private in Sacramento, but publicly he was very supportive of me. Well, the year progressed, and the administration began looking for a health officer. They called a few people around the country. I know because such people called me, and I explained the situation, the history of the department, that it was a good department, that even with the Reagan administration, with somebody whom the administration would trust, that still the job could be done in the department. So I in no ways discouraged anybody from taking the job, but did explain that I was not compatible with the administration. It got down to the last week of the year, by which time I had, of course, been looking around and had decided, was committed to come to UCLA, to the School of Public Health. But that had not been publicly announced as yet, since it didn't seem desirable to do that until quite close to the end of the term. But it was clear that I wasn't going to be reappointed. The newspapers of the state, I guess because news is slow between Christmas and New Year's, picked up on that, and various stories appeared in the major newspapers of the state. And then ultimately, of course, the administration, not having any other health officer to appoint as of the 1st of January, asked me to stay on, but on a sort of day-to-day basis, perhaps month to month. Well, that was no way to be the director of public health, and so I left and came to UCLA. And I remember one cartoon of the period. The newspapers had been very interested in the matter, and as I say, gave it quite a bit of coverage, in which they asked for Reagan's views on the matter. He responded that I was a competent public health official, but that our philosophies differed. And it came around to me, of course, as newspapers always do, to get the other side, so to speak. and asked me what I thought about that. And I said that the Reagan administration and I had some substantial differences during that year of our overlapping administrations, but that in that I thoroughly agreed that we did have a profound difference of philosophy. The cartoon that I remember was a picture of a painter in a building at the glass door of an office, and he had just painted out by crossing over Department of Public Health, and he had just finished repainting below Department of Political Philosophy, which I think expressed very well the newspaper views of the situation. The press had been very favorable to the department for many years. It was difficult for the health officer to do anything wrong. You'd have to have done something pretty scandalous, probably, to have got the newspapers turned against the department. So this was simply typical of their support for both the department and whoever was the director. There were a lot of interesting experiences along that line. I remember one other little episode while I was health officer. During the Brown period, we had an epidemic of influenza in probably 1966, maybe 67, I'm not sure which. And the press picked it up. They were counting the number of cases every day and so forth. Finally came to the governor's attention. And so first thing he did was to, where's my doctor, as he used to call me. He still calls me my doctor when he meets me still on social occasions. Brown then sought me out and found me by telephone in a hotel in Sacramento, deathly sick of influenza. I'd come to Sacramento to work and simply couldn't drive home. Had to rest for a couple of days and holed up in this hotel room. Well, that got out to the press, and it wasn't published, but they knew about it. A couple of days later, we had a press conference about the influenza epidemic in the department. So, in the presence of all of the press there, a lot of questions about the epidemic, someone asked Dr. Breslow, have you had the flu? And I said, yes, I just had the flu a few days ago. Dr. Breslow, did you have influenza vaccine? And while I was waiting to give the answer, which was going to be embarrassing, and everybody knew it, and the press were there just waiting to have fun. I doubt if they would have published it, but anyway, they were going to have fun with me. Bob McGoffin, a very witty member of the communicable disease staff, spoke up, and he said, Dr. Breslow did not have vaccine because he was in the control group.
Well, that's a marvelous answer.
Well, it was really just hilarious, and everybody had a good laugh about it, and nothing appeared in the press. Well, we had some other interesting experiences then. I could go on for hours, but I'll just tell one more. One Friday at 4 o'clock in the afternoon, we had a telephone call, anonymous telephone call, that somebody had just dumped a large amount of LSD, which was the popular psychedelic drug of those days, into the Marin County water supply, the big tank reservoir. Well, such calls always come at 4 o'clock on Friday afternoon.
Of course. Especially if there's a long holiday to follow.
So we had to deal with that. And with just that amount of information, we had an urgent conference. It happened that the key people in the Division of Environmental Sanitation, as we called it in those days, were present, along with some medical and other people, and the press person. So we decided on this course of action, which we followed out amidst a lot of debate. I remember that someone tried to make a point of the fact that in Marin County, you probably wouldn't be able to tell the difference, which was a great libel on the people, at least some people of Marin County. But in any event, we decided on this course of action, first to dispatch a team of engineers and other experts in water supply over to the site and to make an inspection to see whether there had been any sign of entry or anything happening over there. And the report was that there was no sign of any entry. There was a gate that had been locked and no evidence that it had been broken. But still, one could be sure.
Mm-hmm.
So the second decision was that even though there was no evidence of this, that we would run 2/3 of the water to waste and fill the tank 2/3 with fresh water, so that at least it would dilute whatever LSD might have got into the water supply. In those days, we had no easy chemical way of making a decision, so we had to make it on rather gross grounds.
And where could you dispose of such water if it did have LSD in it?
Well, we just ran it into the sewer.
And the effects would not be carried over if...
No, not in well, I mean, I suppose that some could escape from the sewage discharge, but that would be, again, so diluted that it wouldn't have any effect. Well, I doubt that LSD was ever dumped into the Marin County water supply, and I don't think that very many people in Marin County were ever aware of our consternation on that particular Friday afternoon and into the evening. Well, we had a lot of experiences of that sort. But the 1st of January of 1968, I came to UCLA and was thereafter out of the main channels of development in the state.
Who became the director of public health, do you recall?
Yes, a man named Louis Saylor, S-A-Y-L-O-R, who had been a member of the staff of the department, having joined, I think, the Bureau of Communicable Disease Control. I'm not certain, but one of the medical bureaus, after having completed a career as an Army medical officer. And he was selected to become the first director.
But it makes you wonder whether there was real difficulty in trying to recruit a qualified person from outside.
Well, thereafter, the department has had, of course, a whole series of directors, But the Reagan administration systematically dismantled the whole structure for public health that had been built up during the 1940s and sustained almost through the 1960s. For example, they abolished the State Board of Health, which had been an extremely important structure or structural element of public health during all of those years, both the sounding board for and the authority for adopting rules and regulations about public health. Thereafter, of course, they became highly subject to political winds that themselves were not always very consistent. But there were winds this way and that way, even in the same administration, among different people, and with the same people on different days, so that you had no consistency, no stability in public health. And that has been a very sad feature of public health progressively down to essentially to the present time, that the leadership and the authority of the director of public health, buttressed importantly by a state board of public health, has been systematically undercut. And that was the mission that the Reagan people adopted for their approach to this field. Jerry Brown, when he came into office, did nothing to turn that around, because although of a different political philosophy, if he has one, he did not change the fundamental approach of the Reagan administration regarding public health. Namely, it was something to be decided not by people who were competent in the field, with a body of citizens and enlightened professionals who were appointed over a term to look after the public health, but rather decisions would be made by political lieutenants at various levels in the administration. And that continued during the Jerry Brown administration, as it has, of course, during the succeeding Duke Mason administration. One would hope that, as has been recommended in important documents over the years, most recently in a report by the Institute of Medicine of the National Academy of Sciences, in a report called The Future of Public Health, the recommendation is made that essentially state boards of health or commissions of public health be reestablished as a means of strengthening the public health structure throughout the country. So I think we may have a turn, but in California that will depend, as elsewhere, upon the results of an upcoming election. At least it'll depend in part on that. Which way the various candidates will go is, I guess, not yet clear.
So you then came to School of Public Health. Les, while you were in the Department of Public Health, is that when the health care for migrant workers became a program, or was it?
Yes, it was.
With
I can't tell you the years, but a physician named Paul O'Rourke and a medical social worker, Faustina Solis,
yes,
were most prominent in the leadership of that program, and both were highly interested in the health of migratory workers and their families. Both were very familiar with the health problems of those people in California. They made many visits to the camps, literally, where those people lived. We even called them camps in those days, and that's what they were, quite literally. So during the Brown years, and I don't remember exactly when, substantial efforts were made and some funds appropriated to extend the services of county departments of health to those camps quite specifically. It was a special program, somewhat comparable to that for other segments of the population, such as crippled children, pregnant women and their infants, so on. So that was a special program, and a very good one at the time. Those people, especially Faustina and Solis and Paul O'Rourke, did a very good job, you know.
We have in process an interview with Faustina Solis, which picks this up too.
Right. I remember one occasion with Jerry Brown. I don't remember the total background of it, but Paul O'Rourke and I were presenting to then Governor Jerry Brown some proposals for maintaining and even strengthening those programs that had been established during his father's day. We weren't appealing on that paternalistic basis, but the previous governor, and picking them back up again and continuing them after the Reagan years. So here were Paul O'Rourke and I trying to persuade Jerry Brown to do what I've just told you. And Jerry Brown would have none of it. And finally, exasperated, I suppose, with our persistence, he turned on us and accused both of us of simply wanting to get back into state public health service, which was such an outrageous statement that Paul and I just were astounded and made very angry, because neither one of us had thought of such a thing, nor would consider it. But Jerry Brown was so different from his father.
Yes.
As a
he was
political
more
person
like Reagan.
and as a governor. That's correct. They were both, in my view, essentially anarchists. Neither one of them, of course, was the prototypical anarchist in the public mind, at least of a few decades ago. I don't know what people think of as anarchists now, but a few decades ago, people used to think of anarchists as some kind of a wild Eastern European with a big beard and carrying around a bomb that he was about to throw somewhere. Well, Reagan and Brown, Jerry Brown, were not that kind of an anarchist, but philosophically, they were essentially anarchists, and neither one of them believed in government. Government was something to be torn down.
Well, they did their share.
They did their
Each
share.
of them.
That's right. But not enough people have come to understand, as you obviously have, what I think is true, and that is that they were essentially similar, and their fundamental characteristics that typified both of them was a disbelief in government. They just do not think that
I think
government is a way to advance the public interests.
Well, both of them, I think, were really more modern day social Darwinists, that the people who really had the God-given ability would make it. You don't do anything about the others. They're going to perish anyhow. And I think that's characterized both. And the actions of both of them, not just with public health, but with mental health and social services, were very similar.
Right. That's right. Now, what I've said about public health, I know full well, but you can express it, and others a lot better than I, applied to social welfare.
Well, it was a philosophy,
right.
as you pointed out, and it didn't stop with the
That's
health
right.
movement.
That's right. That's right.
So then you went into public health in an academic setting.
That's right. And I've been very happy in that. Briefly, just if you want to hear my career in
Yes,
academic
I do.
public health, has been that I came here, as I mentioned earlier, in January of 1968, having served 22 years on the Department of Public Health of the state of California. I came as a professor in the School of Public Health at the invitation of the then Dean, Steve Gerke, who had been the founding dean of the School of Public Health at UCLA. Gerke had been the chief medical officer in the Los Angeles City Department of Health Services, originally under George Ewell, who was the health officer. And then Steve, after serving for some years in that department, moved to the university when Stafford Warren started the School of Medicine at UCLA about 1950. Steve came sometime early in the 1950s. And he came in as the founding chairman of the Department of Preventive Medicine in the School of Medicine, which graduated its first class in 1955. So it must have been admitted in 1951.
Mm-hmm.
Thereafter, Steve established what was called in those days the Southern Branch of the School of Public Health in the University of California. The School of Public Health itself was headquartered, located in Berkeley, on the Berkeley campus. The dean of the School of Public Health at Berkeley was quite worried that the rapid growth of the UCLA campus, and particularly the medical campus, School of Dentistry, School of Nursing, that were being planned, would eventuate in a separate school of public health, which he was obviously going to be dead set against. But Steve Gerke was very astute and successful in developing the Southern Branch of the School of Public Health into a separate School of Public Health at UCLA, which was recognized, I think it was 1960. And began to develop slowly, but not in a very strong fashion. During the early 1960s, some very important people came to the campus in those days, among them Milt Romer, whom I mentioned, who was a national leader in medical care studies, still is, and others were attracted to the school. But it wasn't a very big school, and it didn't have a very big faculty, and it wasn't very strong. But by 1968, it had begun to get a little momentum and seemed like a very attractive place for me to come. Steve had kept the chairmanship of the Department of Preventive Medicine in the medical school, at the same time serving as dean of the School of Public Health during the early and middle 1960s. In 1970, a couple of years after I'd come here, Steve became ill. He had some cardiovascular trouble and decided that he had to give up one of the positions, whereupon the dean of the medical school, still Chairman Mellenkopf, conducted a search and invited me thereafter to come to the medical school to be the chairman of the Department of Preventive Medicine in the medical school. That was in 1970. Steve kept the deanship of the School of Public Health. 2 years later, however, Steve got further sick, and in 1972 had to give up the deanship, whereupon the chancellor conducted a search for the dean of the School of Public Health and ended up by asking me to be the dean of the School of Public Health. Whereupon I talked with the dean of the School of Medicine and then with the chancellor to say, look, this is getting a little silly. I come to the School of Public Health and you recruit me to be chairman of preventive medicine and then back to be the dean of the School of Public Health. It appears that this is a fairly close-knit situation, and why don't we just recognize it and put it all together, which was done. In that the medical school dean allocated the faculty and the space and the Department of Preventive Medicine to the School of Public Health. In return for which, of course, the School of Public Health was to function, has functioned, essentially as an undergraduate teaching department in the School of Medicine. So it has been all put together and has continued to the present time.
So it's under the umbrella of the
Dean of the School of Public Health. So that the Dean of Nursing and Dentistry, Medicine, and Public Health are at the same hierarchical level with the Chancellor. Each of them reports directly to the Chancellor. But just as the medical school takes responsibility for teaching certain of the basic sciences in the School of Dentistry, so the School of Public Health takes responsibility for teaching epidemiology, social medicine, other aspects of preventive medicine to the medical students.
So it's a very integrated kind of relationship.
That's right, yeah. And that's quite a healthy thing, we believe. It certainly has served everyone at UCLA very well, faculty and students and administration. I think all have been happy with that. And I hope that it'll flourish. Seems to be flourishing now after we've gone through a complete rotation and new sets of deans. It still is strong. Quite different from what happened when Reagan became the governor.
Yes.
What happened to the infrastructure. Anyway, I then continued as dean from 1972 until 1980, when I retired and began to draw on my benefits, having served those many years in the Department State Service and in the university, which is for retirement purposes a continuation of state service if there's no break in the service. So it became just too attractive for me. Since I wanted to leave the deanship, I was then 65 years old and thought that it was time to leave. And after a year or two of persuading and the usual kinds of delay in such circumstances, I was relieved of being the dean, and at my request, and have continued, however, to be re-employed by the university under an arrangement that the University of California has for re-employing without tenure and on a year-to-year basis such faculty as by mutual agreement of the university and the faculty member should be re-employed. So I've continued since 1980 to serve in the university in two capacities, one in health promotion, the other in cancer control work.
Now, are those within the framework of the School of Medicine, public health, or are they totally discrete, spelled with an E-T-E?
Well, yeah. It's mixed. I'll try to explain it to you. The health promotional work that I do is principally related to a health promotion center that has been established at UCLA in the School of Public Health. So that's in the School of Public Health. In a center which the Dean of the School of Public Health asked me to take the lead in organizing. I can give you any amount of detail on that you might want to hear. The other is a cancer control division of the Johnson Comprehensive Cancer Center at UCLA. And that center, the Comprehensive Cancer Center, of which our Cancer Control Division is a part, reported to the Chancellor directly until a year or two ago, when the Chancellor divested himself of all such connections with various elements on the campus.
Why would it have reported to him in the first place? What was the rationale for that?
Well, the rationale in the first place was that it was a multidisciplinary and multi-school element of the campus. It had, of course, strong participation, I would say predominant participation from the School of Medicine, but there was also strong participation from the other health science schools, nursing and dentistry, and of course public health. Likewise from letters and science, various other elements of the campus. The Molecular Biology Institute, which is a part of the letters and science college on the campus, has a great many participants in the Cancer Center. So the Chancellor thought, and several of us who served on a policy advisory committee, I chaired it for a number of years, advised that it report directly to the Chancellor. And that was the case for many years. But about a year or so ago, the Chancellor decided that too many people had persuaded him of that, and that he was going to divest himself of all of those things and do the best he could with allocating the responsibility back to the deans. So what has happened then is that now the Cancer Center at UCLA reports to the Dean of the School of Medicine, and he has vowed to maintain a multi-school advisory committee on the Cancer Center. So the answer is that now the Cancer Center reports to the Dean of the Medical School.
It's a complex organizational arrangement, but there's a lot of logic in its being this way. It's too cumbersome otherwise. I guess.
Yeah.
Yeah. So your titles now.
Well, my titles now are the director of the Health Promotion Center, School of Public Health, UCLA, and I think it's still officially something like associate director or something like that of the Cancer Control Division. The history of that, just very quickly, is that it was started by a very strong, good person 10 or plus years ago, and was getting a very good start when he decided to return to the National Cancer Institute, where he'd had a good opportunity and another one seemed to be looming. When he did that in the early 1980s, the director of the Cancer Center in those days, and still, Dr. Richard Steckel, asked two of us who were in the division, Helene Brown, who's very active in the National Cancer Advisory Board and other cancer circles, and me, to take the responsibility as co-leaders of the Cancer Control Division. We did that with the intent of trying to keep building up the Cancer Control Division, but to finding someone who could really take the lead in a way that neither Helene or I felt that we should or wanted to. And that has happened in that Ellen Gritz, a psychologist, has come into the leadership of the Cancer Control Division. Both of the things that I work with now, the Health Promotion Center and the Cancer Control Division, are located in this floor, on this floor of this building. I didn't tell you much about the days when I was the dean of the School of Public Health. But that was also a very interesting period for me personally. I'm not sure how relevant it is to your whole series, but they were very fulfilling years for me. I was very happy to have the responsibility of succeeding Steve Gerke, who had founded the school, and of keeping it going and building it. The greatest thing that I did for the school probably was not so much by my effort as it was simply to bring to attention of then Vice Chancellor Saxon, who later became the president of the University of California, to bring to his attention the very great need for more faculty in the School of Public Health. Steve had been one to build things. That's often the case with a founding leader. So one of the ways that he built things was to build the student body. And he did so with some federal funds that were available to assist the development of schools of public health around the country. Somewhat comparable to the
interview with Dr. Breslow, a continuation from cassette number 2, side B.
Similar to the federal funds for building the hospital infrastructure of the country by allocation to the states, the federal government also allocated funds to universities for schools of public health. And the UCLA school, as well as the Berkeley school, of course, was benefiting from those funds. With those and other support that he got from the university and the campus, Steve was rapidly building the school and was successful in getting a building, a part of the UCLA Medical Center, to be devoted to the School of Public Health just about the time that I arrived. As a matter of fact, the school was going to be moving into that building. But when I took over, the student body had outrun the faculty in size, and I brought that to the attention of Vice Chancellor Saxon, who had the responsibility for such academic affairs on the campus, and he immediately allocated a 50% increase in the faculty of the School of Public Health. That is, to jump from 30 members in the faculty to 45. Mm-hmm. That was quite a...
That's a substantial jump.
Yes. You've been in academic life, so you appreciate what that means. Now, how far do we get?
You were talking about the structure of the School of Public Health, the increase by 50%.
That made UCLA quite a notable school of public health nationally, because the other deans quickly became aware of what had happened here, and to have state-funded positions increased by 50% in one jump
quite remarkable.
Was a very remarkable achievement. So they sort of wondered what was going on here. But that gave a great boost to the school, both locally and internally, as you can well imagine, and to the national reputation of the school, which has continued to grow over the years, I think it's fair to say. And now, of course, the school is considerably larger. I think they're up to 65 or some number of faculty. They need a lot more.
Well, we have that.
I hope
we
that's
have
recorded.
A record of that now.
Even though I'm 10 years out of the deanship, I can affirm vigorously that they really do need more. But the school is doing, I think, very well. So I'm happy to have been a part of that development. Some goofy things happened in the course of my deanship. One that's sort of personal, but may be interesting for people to hear sometime. The Association of Schools of Public Health in those days met annually during the summer at one of the schools. And 1972, the fall, it was meeting in Los Angeles. That was just a few weeks after I became the dean at UCLA. The number of schools at that time was something like 12 or 15 in the country. Now it's up to, I think, 25 or more. So, as the host dean, I had, of course, the visitors come to my home for a party the night before the official business meeting opened. And at that party in my home, a small group of the deans, I guess originally 2 or 3 of them only, decided that I should be the candidate to be the president of the Association of the Schools of Public Health. Not because I was such a great candidate, but because the person who had been in line to succeed into the presidency of the association was someone that they didn't feel was the appropriate person to be the president of the association. And of course I knew absolutely nothing about this. I didn't know who the officers were.
The person would ordinarily have followed a
so sort of a line.
Yeah.
Correct. And so right in my home that evening, this conspiracy, I suppose some people might call it, was carried out. And only at the end of the evening did the leader of that particular group tell me what they proposed to do. In fact, he did so after essentially all of the other people had left, and there was no opportunity to respond. He was simply telling me. He wasn't asking me or consulting me. Well, the next day, of course, they did that, much to the discomfiture of the other man, and much to my embarrassment. But I was sort of stuck. There wasn't any way I could really say I wouldn't do it or get out of it. And they were determined, and they had decided right during that party, and with the other man present, but of course not a party to the various conversations that took place. That's the closest I ever got to politics and public health. And as you can see, although it was physically close, I was unaware of what was going on.
This other man was in the group too.
Yes. Oh yes. Well, there were,
Yes.
a dozen or 20 people milling about. Some wives were here and so forth.
So you did become president.
I became president.
While you were dean of public health, do you recall any specific situations of influencing the State Department of Health Services? Was there much interaction? I was just wondering about the irony of now being in a position of special recognized international expertise in relation to the department you've been heading. It's really a matter of personal curiosity on my part.
Right. Well, I'm just looking, as a matter of fact, at my CV for those years, beginning in 1972, which is, I think, the years of which you were speaking. Reagan was governor from 67 through 75, is that right?
75.
Through 75. So I was, during that period, 72 on, a member of the Medical Advisory Committee to the Air Resources Board. I was, well, this is during the period of Jerry Brown, I guess, chairman of the Task Force on Quality of Care of Prepaid Health Plans. Then also during that middle period, the so-called Little Hoover Commission of California, which you probably know about, as a body that consists of people appointed for long period of time, I think it's 6 or 10 or more years, to have a kind of a watchdog look at what's going on in the state government. I served beginning in 75 and continuing to 76 as chairman of a task force on operations and organization of the Department of Health as a part of that commission, so-called Little Hoover Commission on California State Government Organization and Economy. then I served in various other capacities every year or two to various ones down to the present time. Now, the school has also, of course, had, you asked about the school during my deanship, also has had contacts with state government. And I recall that some of our faculty, for example, have worked on various state committees and commissions and bodies doing the kind of work that faculty members, especially in such a field as public health, should be doing. I did not have a great part in it until very recently again I have been drawn into activities in connection with Proposition 99, namely the implementation of the health education account in the allocation of funds from the revenues derived from the increased tax on each package of cigarettes now in California. The total of those revenues in a year is estimated to be something like $600 million. Most of it goes for medical, hospital, some research activities. 20% of it, however, is earmarked for health education, prevention of tobacco use among young people. And I've served on a state health director's advisory committee for that health education account, what to do with that money. Mm-hmm. And now I'm appointed to the official statutory so-called oversight committee. I'm appointed to that body by the Speaker of the Assembly, Willie Brown. So my principal interest in state government the last year or so has been in that connection.
This matter, this interest in cancer and tobacco control has been a continuous thread in your professional and volunteer activities, has it not?
That's right. I started, that's very perceptive, it's been a continuing thread. I started in it in August of 1946, when I think I remarked on the earlier tape, we received funds for cancer control from the federal government allocated to the various State Department of Health Services. And with that allocation to California, we built the Bureau of Chronic Diseases. Not limited to cancer, but that was the core, the initiating force. And we developed cancer control activities, a tumor registry, which has just now become statewide, and other activities in cancer control. A lot of studies of cigarette smoking as a factor in lung cancer, occupational factors in cancer, other investigations and activities for control we carried out in the State Department of Public Health. And since coming to the university, I have continued it. And since 1980, have emphasized that aspect of the work, so that this year, for example, I served as a consultant to the American Cancer Society on their review of their orientation, what they're going to be doing, and gave a talk at their leadership conference a few weeks ago, which they invited to hear my views on what the society should be doing. I've been very active in the cancer control activities of the National Cancer Institute. Served as the founding chairman of a board on cancer prevention and control, which led to the formation of a new division and a great strengthening of that division in recent years in the National Cancer Institute. I've also been in touch with some new developments, very new developments, in the Centers for Disease Control, which has an interest now in smoking control and in cervix and breast cancer in women. So I'm involved with that body. And next month we'll be going to Hamburg, Germany, for a meeting of the International Union Against Cancer, which has asked me to serve, and I am serving as chairman of a small committee to carry out some demonstrations of the development of a national cancer program. So they are seeking funds and using some of their own funds to carry out some investigations in a small number of countries, different parts of the world, on how such countries should develop national cancer control programs. I guess I was asked to do that because I also, a couple of years ago, finished a book for the World Health Organization on cancer control policies. And to jump way back, let me say that most of my time in cancer control, however, is not state or national or international, but is in Los Angeles, where our cancer control division, with substantial program research support from the National Cancer Institute, is intensively engaged with the Los Angeles County Department of Health Services to strengthen that department's cancer control capacity. And I've enjoyed that work over the last 4 years, and that's continuing.
So that cancer prevention and cancer control has been kind of a continuing crusade for you over a number of years. Has there been any other particular dimension of the field of health that you've been as consistently involved in?
Well, I'd mention two things in response to that. They're hardly answers, but they're responses, I hope, to the question. One is that I've had a continuing interest in the whole of public health. Although I have devoted myself to certain aspects of it, particularly cancer, as you point out, and some others, but that's been a leading one, you're right, and a continuing one for 45 years now. I've had an equally strong interest in what I would now call the whole of public health, and that has taken the form of participation in the American Public Health Association, serving as its president, for example, in 1968, the first year I came to UCLA, and other activities in the American Public Health Association. Also, in working with the schools of public health, as I mentioned in a peculiar way during my first year of deanship as the president of the Association of Schools of Public Health, an opportunity to look at the whole of it and try to influence it as you can with the deans of public health academia, at least. More recently, I served as a member of the Institute of Medicine's Committee on the Future of Public Health, and was a party to the report of that committee, namely the Future of Public Health, in which we lay out what we think is the future of public health, beginning with the definition of public health. So I would say that I have had that interest in trying to define and delineate and to, as best an individual can, exemplify an approach to the whole of public health. And that has, of course, meant at various times advocating things which were outside the accepted domain of public health, as, for example, medical care administration, which, to my mind, is a part of public health. The Institute of Medicine report defined the mission of public health as fulfilling society's interest in assuring the conditions in which people can be healthy. Well, to me it's perfectly obvious that one of those conditions is access to medical care when you need it.
But better prevention.
Better still, prevention. Absolutely. And I simply wanted to mention that that definition of public health, although it's not my words.
That's an interesting definition. I hadn't heard it. But I accept it philosophically.
That's right. And I was very happy to be a party to that philosophy as expressed in that report. So that's been an interest. The other, and a more recent interest of mine, perhaps I should take a minute to tell you about, because it's the other response to your question. What besides cancer control has been a long continuing theme? And so my first response was the whole of public health. And the second response is health promotion. It has seemed to me for some time that in addition to assuring conditions in which people can be healthy, as a matter of fact, as a part of assuring those conditions, it is necessary to take account of the fact that people in many societies do have choices about what they do that will affect their health. For example, every day you and I decide, so to speak, whether we'll smoke cigarettes, whether or how much alcohol we'll drink, how we'll drive our automobiles, how much, what kind of food we eat, what exercise we obtain. All of the things that we know affect our health. Now, you would say, well, I don't decide that every day. I have certain habits. I don't smoke cigarettes. I drink very moderately, if at all, and so on. That's true. But you and I could decide any day what we're going to do about those matters. Everybody can. But that, of course, is only half of the story, because you and I know very well that those decisions are not made in a vacuum. They are dependent upon the social milieu, the history of oneself, family, relationship to others, peer groups. It's the social influence as a whole on people. And that social influence is one of the very important conditions in health and in assuring which one can say is extremely important for health. In any event, going back to the time when I was the study director for the Truman Health Commission in 1952, you may recall that episode, I have been interested in the question and pursuing the question of the relationship between personal and community or social action for health. You may recall there was a period 10 or 20 years ago when suddenly it became popular to speak about individual responsibility for health. And some of my colleagues attacked me because they thought that I was a part of that movement. Well, I was, to the extent that I've just explained to you, that there are such individual decisions. And to the extent that we can, we should try to influence those decisions.
We were talking about your interest first in cancer control, then health, public health, then health promotion, and the role of individual responsibility.
And social responsibility in public health.
Mm-hmm.
Right. Well, as I see it, one can look at this as an instance of systems, and one can take it at any level, the level of the individual, if you want to regard a person as a system, and you certainly can, interfacing with an outside world, including the social conditions of that world. You also can look at the system of the community in which there are individuals interfacing with social as well as physical conditions of the community. So it's a question of what your focus is at any particular time, as long as you recognize that these are interfacing systems. So I do affirm the importance of individual actions for health promotion, but also insist that one cannot take these as isolated actions, that they occur in the system of a community. And if you want to influence an individual, you can deal with the individual. That's what physicians do, and nurses and clinical social workers and all of the people who deal with people and their individual health problems. Try to assist individuals as best they can to assume and take responsibility for their own health. There are limits of that, of course. The other focus is to concentrate on the social conditions in which the whole community of individuals must act, and to assure, as the Institute of Medicine report affirmed, that we assure the conditions in which people can be healthy. That's the point of public health. Well, I have been interested in this matter of individual and social responsibility for health, and how over the years it has evolved into what we now call health promotion. That is getting to be a popular term. And most people evidently think of it in connection with this interface between the individual and society with respect to the conditions that people must live in and in which they must make decisions about their health. one doesn't decide to smoke cigarettes in 1860 because there were no cigarettes in those days. And one doesn't decide typically to smoke cigarettes if you're raised in a family of some religious sect that eschews the use of tobacco. Or one doesn't decide to smoke cigarettes if you have a college education and enough understanding to realize the damage to your own and other people's health that can follow the use of tobacco. On the other hand, there are some other conditions in which people are induced to smoke cigarettes. And one of those conditions is the advertising milieu to which we are subjected very overtly and very subtly. So in public health, we are concerned with all of those conditions that influence people's smoking or other habits that pertain to health. That's the typical way of thinking of health promotion. And I have been involved in that also on a continuing basis for some years. But going back to that 1952 report of the President's Commission, which to my mind still is one of the best formulations of this issue. Mm-hmm. But now, in the last 5 or 10 years, I've been thinking about another meaning to health promotion. And that is something more than the prevention of disease. When we speak about prevention, we think about disease. That means to prevent all of those terrible plagues that we had in the past, and also to prevent cardiovascular disease and cancer, and so on, other diseases, which increasingly we have the knowledge to do. We can prevent those diseases, and increasingly are getting down to that task. That's disease prevention. But there also is such a thing as promoting health. It's not the same as disease prevention. To me, promoting health is enhancing the capacity of people to live in the environment to which they are subject. Now, some of us, like you and me, happen to have very favorable environments. So our health has got a pretty good chance. And we think about it probably more than people who are living in circumstances which do not permit the same kind of health, because they're tougher against health than the conditions in which you and I live. But health for either set of people is the capacity of the people, the reserves of people to stay in balance with, to maintain health in the presence of the conditions where they are living. So I think of health promotion as being not only this social movement to assure conditions in which people can make healthful decisions, but also I think of it as an individual matter in which people can really build their own health by maintaining proper blood pressure, by keeping a low blood cholesterol, by maintaining proper weight, by keeping up appropriate exercise, and so on. And that builds the reserves of the body to deal with whatever the conditions are that you might reach. I like to illustrate this with the story of a friend of mine, the dean of another school of public health, who told me this story. He said that as a scuba diver, he was once, a few years ago, 50 or 60 feet underwater. to go way down, and they have tanks and all kinds of equipment and so forth. The equipment failed, so that he was not delivered oxygen. He was not drowned, inundated with water, but he simply did not have oxygen. For some minutes, it isn't clear how long, but it was several minutes.
Scary in any event.
In all probability, sufficient to have either killed him or left him a vegetable with his brain wiped out, because the brain is most sensitive to the temporary lack of oxygen. Other parts of your body can keep going. But although the exact number of minutes isn't clear, it was evident that most people would not have come out of it. In fact, extremely rare for a person to come out of that exposure to lack of oxygen, completely retaining his brain power, with the exception of memory loss for that event. He couldn't remember the event of the scuba dive, but that's the only cerebral impact. How did it happen? How could such a person have that degree of resistance, reserve to deal with that extreme condition? The explanation he advanced, and I think it's probably true, was that he'd made a habit for years of swimming underwater. In addition to scuba diving, he was an underwater swimmer. There are people that do that. I couldn't do it, but he did it. So he would customarily swim for some minutes. That's a long time underwater, even a very few minutes. And he had trained himself somehow to do that. Well, I mention that as an extreme anecdote, no science to this, but it illustrates the point that if one has the capacity to keep the blood pressure down and all other systems of the body in a healthful state, then one can say that you are healthy and that you have been promoting health. So I like to think of health promotion in that sense, of not just preventing disease. That's just one side of the coin. The other side of the coin is to build in a positive way the capacity, the reserves of the human organism to live. Well, that's my interest in health promotion.
That, I think, is a very good point for closing. I really want to thank you very much for a very stimulating couple of cassettes and few hours. And if you think of other things you wish you had said, let me know.
I will. I probably said too much.
No, never.